Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
What investigations? Now comes my favorite question. So what do you think? What all? See, I'm going to give you a list of maybe one or two, and I'm going to ask you maximum, because with your own clinical acumen, you should, once if you give the answers tonight, that's going to register in your mind for a really long time, at least for the time your DNB is passed, right? So think from your own mind, what investigations? The first one I've told you, the key investigation is the blood culture, because obviously she's in sepsis. There is some organism in the blood roaming around causing all the systemic manifestations. So first is blood culture is the key investigation. What else? I've already given you a list in the beginning of the class. All right. So I expect quick answers from all my lovely and intelligent students, and very shy students also. Majority of you are sitting and letting others answer. Very good, Kaushik. CBC is very important, and many other students don't want the names to be taken. So I'll keep a track. I will not say your names, but keep answering, guys. So CBC, very good. Nazima, CBC, CRP is very important. Blood is very important. Urine is very important. High vaginal swab is very important. If she's having any symptom, okay, symptom specific investigation is very important. Why do you want to go for an LFT, KFT for a baseline? Whether you want to, because she'll be on antibiotic for a long time, so you want to just get it done, all right? Coagulation profile, okay. If she's bleeding, maybe yes. Otherwise, not a very, regular investigation. Yes, definitely high vaginal swab is very important. A swab from the wound, suppose the wound is the, focus of infection, or you're having cup sputum is the source of infection, UTI, urine. Did anybody say urine culture? Yeah, urine culture. Okay, good. You've missed a very important test. This is fine. You're right now you're focusing on the test for the sepsis. But because of sepsis only, there's a very important other test which you cannot miss. And if you do miss, sepsis is incomplete. It's right there in front of your screen, staring in your eyes. It's the serum lactate. If you miss that, you missed the entire sepsis. Like blood culture is the key investigation, serum lactate is at power. And can you tell me what serum lactate does? Why do you want to, get a serum lactate done? Can anybody tell me that? Yes, Suja, very good. DIC, dimers, fine, but not here, not so much, no. What are my intelligent students writing? Let me see. Well, lactate actually is a feature of tissue hypoperfusion, which is the hallmark of sepsis, In fact, I would say severe sepsis, because from there, the patient deteriorates very fast. Septic shock, that means the body has done so much harm to its own self. Okay, the systemic infection has become so, the complement cascade has reached to that level. This was what was happening with the COVID patients. I hope you know this thing, right? That it was such a marked inflammatory reaction from the body that those patients who entered into that whirlpool, that spiral, could not make it out, because we were not able to understand what they're going through. But this is what happens when the body mounts such a huge, heavy complement cascading kind of a response on any foreign agent. Then the capillaries, they start becoming leaky. The blood, it starts becoming thicker. We don't think of thromboprophylaxis at such a time when the patient is coming up with this infection. Why will we think about it? Actually, what's going on is this: the capillaries, they're becoming more and more leaky. The more and more seroma, the serous fluid drains into the third spaces. You have hypoperfusion. The BP goes down. The kidney doesn't get enough blood. There is anuria. There is hypoxia. There is widespread, and this causes more inflammation, more tissue injury. All right. And of course, it causes thickening of the blood, and the other spiral starts to happen, the thrombosis and the triad of death. Correct? Anyways, what's very important in this entire episode is the serum lactate, because that tells you the tissue hypoperfusion, which is the hallmark of sepsis. And why I just told you the entire etiopathogenesis of the sepsis, which nobody's going to ask you, but you need to know the pathophysiology. Yeah, I think this question has been asked once, pathophysiology of sepsis. So this is exactly it. If you have learned the pathophysiology of preeclampsia, remember, so there was an injury, the tissue injury, which causes the cascading of these all entire different events. So you have leaky capillaries there as well. You have tissue injury there as well. You have kidney, kidney injury there as well. You have thrombosis there as well. So these are the reasons for increased lactate. And what does lactate tell you? More than 4 millimoles over here, you have the answer. Serum lactate more than 4 millimoles is indicative of hypoperfusion, which is why it is very, very important, essential step to be. We say that in sepsis, we have to take three things, give three things. So you have to take the samples. You have to take the samples of obviously the blood culture. You have to take the serum lactate. You have to go for a CBC complete. You have to look for the urine output. You have to give IV fluids, and you have to give IV antibiotics. So these are three things that you give and three things that you take. So these three things, if you remember, that you have to take the blood cultures, you have to take the CBC, you have to draw the CBC, you have to see for her urine input and output, and you have to give them IV fluids, you have to give them IV antibiotics, and you have to be very, very watchful for their vitals. You are sorted with the management of sepsis, and it is going to come in the slides to come as well. Like I told you, you can take other examples which are suspicious of the focus of infection. Like I told you, so many examples. You can take the pus from breast abscess, or you can take the urine for urine culture, stool for stool culture. These are all specifics wherever you have a clinical suspicion of a focus of infection. But apart from that, you have no CBC, urea, electrolyte, C-reactive protein, all that you have covered. Throat swab, if at all, that is one more source of infection. If diarrhea is particularly offensive, that which I just told you, you have to go for a stool culture. And a paucity of leukocyte and the presence of gram-positive cocaine chain, that tells you the streptococcus. Paucity of leukocytes, okay, indicates streptococcal infection, correct? Sometimes because of hematoma, a wound infection, an infected hematoma, or a collection of pus intra-abdominal, you will see thrombocytosis. I have seen this. There was a patient of one of my consultants who had a post-op hematoma, a pretty big one. She came back from her home with that hematoma. And all her tests were fine. She was never in sepsis. We caught her before in time. She was just having this swinging pyrexia, and we called her back and we started on an antibiotic. There was a hematoma because of which we had to hospitalize her. All her reports used to come fine. There was leukocytosis, yes, but it was decreasing. Only one thing maintained was thrombocytes. She had 6 lakh platelets. It was not going down, it was maintained. It stays on. That's not a feature to be monitored for, but that tells you something, that there is a collection of pus or a hematoma. In her case, it was infected hematoma. Yes, it was infected. Now, tasks to be performed in the first 6 hours of the identification of sepsis. From here starts the very, very important part. This is the management of sepsis, guys. So how do you go for a patient who has come to you with suspected sepsis? First of all, you have to identify whether she's in sepsis or severe sepsis, whether she requires an hospitalization. She does require hospital admission. Start with obtaining the blood cultures prior to the antibiotic administration. Antibiotic you have to give in 1 hour. Before that, you have to take out the blood. Administer broad spectrum antibiotic within 1 hour of recognition of severe sepsis. Measure serum lactate. Okay. In the event of hypotension, which I just promised you, how will I tell you about this? You have to deliver her initial minimum 20 ml per kg of crystalloid. 20 ml per kg of crystalloid. You have to give her vasopressors for hypotension if it's not responding to the initial fluid resuscitation. So you have to apply. Suppose the patient is not maintaining on just IV fluids alone, please give her vasopressors so that she maintains at least her urine. Otherwise, she's going to have acute renal injury. In the event of persistent hypotension, despite the fluid resuscitation, and or the serum lactate is more than 4, you have to achieve the central venous pressure of more than 8. And this is actually a protocol of the ICU experts. But I'm still telling you because it was there in the book, and I needed you all to at least see it once so that if you remember, it's very good. So you have to achieve a central venous pressure of more than 8, achieve a central venous oxygenation of more than 70, and a mixed venous oxygenation saturation of more than 65%, guys. How should the sepsis in the puerperium be managed now? So, of course, you have to cite the focus of infection, deal with it. Give her uterine, either there is a uterine RPOC evacuated, breast abscess, drain it, wound abscess, again drain it. Broad spectrum antibiotics should be given to cover this entire procedure and then follow up. So if there is, first of all, it's very important for you to find out if there is a focal cause of infection, because you can treat it. Now, you can just, like I just told you, if there's an RPOC, just evacuate it. If there is a pus, drain it. Because you're taking out chunks, debulking surgery kind of. And then whatever remaining is, you start from there. Administration of IV broad spectrum antibiotics within 1 hour of suspicion, okay, is recommended as a strategy of surviving sepsis. Correct? If you feel that there is no other source of infection, only the genital tract is suspected, then you have to treat her with a combination of high-dose broad spectrum IV antibiotics. A combination now, which antibiotic you have to give? That if you're telling me to give antibiotic, broad spectrum antibiotic, which one and what is the dose? So I hope you do know that there is the piperacillin, tazobactam, they come as Pibzo. How many of you have already given this Pibzo, and can you tell me the dose for everybody's sake? How many of you have given Pibzo, guys? You have to write this down for the post-OT notes, right? Or a patient who's deteriorating, you're there in the ICU with your consultants, you must have written these charts, you must have written this so many times. Very good, it's 4.5 grams, that's absolutely right. But how often do you give it? Is there a dose for that? BD, TDS, QID? Great. So my students already know everything. Why am I taking a class for them, right? These students already know, and they're always there in the class, correct? Good, very good. So you can give this combination. Carbapenem. Which carbapenem have you given to your sick patients? Which carbapenem? Which one do you usually give? Okay. Yes, me too. We usually have given meropenem, right? I've not seen any other carbapenem being given. Meropenem I've seen. Plus, either of these things, plus clindamycin. That is the one which provides the broadest range of treatment. This is what had I been in your place, this is the only one line I would have been waiting for the entire, journey of sepsis. Karna kya hai? What do we have to give to the patient? So finally, the answer is there right in front of you. You have to give injection, Pibzo, 4.5 grams, TDS, IV, along with clindamycin. Now, give me the dose of clindamycin. 300, 600, 900, TDS, IV, IM, what? Give me that dose. See, this recommendation is not there in the dose recommendation is never there. It responds to the patient's body habitus, the body mass index, and to the severity of infection. So it's not given, but we know, right? So we give IV clindamycin usually 600. Okay, usually 600 milligram TDS, correct? And this is the best. This is the best. So if the patient, if you're really in doubt, you feel this patient is going in sepsis, the patient is not okay, you had an extensive surgery, your OT setup is not, up to the mark, you have a small clinic, you have a small ward, the patient is also low socioeconomic status, you please give her Pibzo along with clindamycin. Hopefully she should be fine. But she's not in sepsis. This is prophylactic. But people are going to kill me for telling you this. But yes, that's how we function in India. You just give her this, you're going to be having a peaceful sleep. MRSA may be resistant to clindamycin. Does clindamycin work for MRSA, guys? First of all, tell me that. You just told me about vancomycin and teicoplanin, but do you think clindamycin works for MRSA? Does it work for MRSA? Methicillin resistant? Clindamycin is good or doesn't work? Come on, its answer is right in front of you. It's resistant. It's resistant, maybe, but usually it is. I have a beautiful chart at the end of this discussion, guys. Just wait for it. It's a beautiful chart. I think you should have that chart in your mobiles, all of you. Just take a picture today and save it in your mobile, okay? Why? Because sometimes in the rounds and sometimes with some patients, it's very important for you to remember. Which combination will be best? I just told you the best combination because this is going to save all your purposes. But here also, MRSA usually remains uncovered. Let's go to the chart and then we'll come back to this line again. Some few antibiotics only breastfeeding women have been avoiding, but otherwise most of them are safe enough. Clindamycin is not nephrotoxic, and it has an extra advantage of switching off the production of super antigens and exotoxins specifically being released by staph and strep. Okay, now look at this. And I'm going to just discuss a couple of antibiotics here with you because this is my favorite as well. This chart is really my favorite. Coamoxiclav, the amoxicillin that you would talk about most of the time, it does not cover MRSA. It does not cover Pseudomonas. It does not cover the ESBL producing organism. And then you have metronidazole, which only covers the anaerobe. So whenever we give metronidazole, what is the purpose of giving metronidazole? Only for the anaerobes. So not gram positive, not gram negative, nothing. It covers the anaerobes. Clindamycin, most of the strep, most of the staph, most of those organisms which are responsible for causing puerperal infections, all are covered. But clindamycin is a wonder drug actually, right? Including many and see, I just told you, does it help with the MRSA? Not. The answer was maybe resistant. MRSA may be resistant to clindamycin. Clindamycin works. See, it covers most of the MRSA, includes many MRSA and switches of the exotoxin production. So clindamycin is not only helpful for staph, strep, the most notorious organisms in puerperium, but it also helps in many MRSA, right? Not all, but many. Piperacillin, carbamidins, they cover most of the organisms, but not MRSA. And they are renal sparing, so they are our favorites, right? This is very important. So if a patient comes to you with, renal toxicity, she comes with you with AKI, she's in sepsis, or she comes to you with pyelonephritis, and she's, that is the reason for her sepsis, then you can easily give Pibzo along with Pibzo or carbapenem along with clindamycin. Yes. Treatment adverse effects. This is not the time for you to be taught this. What is the role of IVIG? Have you heard ever IVIG being given in your hospitals in the setting of puerperal sepsis or post-op sepsis for that matter? Anybody in any hospital has IVIG been given to combat the sepsis? Anyone? Let me see. What are my students telling me? What anaerobic? Okay, no. Same here. We've not been giving any IVIG, but it is recommended by just imagine this is the Royal College of Obstetrician Gynecologists RCOG guideline, guys. This is a recommendation. It is recommended for severe invasive streptococcal and staph infection because before it is too late and you're losing hopes on the patient, before she starts circling, you have to give her IVIG as a last resort. It's an immunomodulatory effect. Staph, strep, sepsis neutralizes the superantigen. Obviously, you are postgraduate students. It's at the level of books and at the level of recommendations. Only your senior consultants can give, and you can just go and find out through your power of net that do we have IVIG? What all preparations do we have? Talk to your seniors and your consultants that, ma'am, can we give this thing now? And I want this homework in the next session. I'll be asking you about IVIG, all right? Since we've not been giving, that does not mean that we do not know anything about it, all right? So this is your homework. You're going to find this thing out and let me know in the next class, all right? And I'll give you an insight into what exactly is IVIG and whether it is being given anywhere, whether research settings, but here we have a recommendation right in front of us. So it's definitely above and beyond the research part. But are we practically using it? That's another thing. High dose IVIG have been used in pregnant and postpartum women and is effective in exotoxic shock. But there is little evidence of benefit in the gram-negative sepsis, the main contraindication being a congenital deficiency of immunoglobulin A. Anyways, what my idea was that you see that a strep, what do you expect usually in a post-op patient? Either a staph infection or a staph infection, or maybe an E. coli infection. So if you see that the broad spectrum antibiotics are not, letting it improve, before finally it's too late, just try IVIG. That's the place of IVIG. That's the role of IVIG. So they should be cared for in the hospital, correct? Now comes the most important part, which I also wanted to discuss with you, whether this patient should be admitted in the hospital or in the wards or in the ICU. So there are some couple of patients whom I would want to see in the ICU straight. Who are those patients? The ones who have hypotension or raised serum lactate despite fluid resuscitation. So you started with fluid resuscitation, they're still maintaining, hypotension. The BP is not improving. That BP can improve very fast, right? It's not improving. So you immediately transfer to the ICU. Patient who came with pulmonary edema. The patient who've been put on mechanical ventilation. The ones whose airway had to be secured. Patients who are showing signs of acute renal, insufficiency. Consciousness, the patient is not conscious, she's disoriented. She's too drowsy, she's too lethargic, she's not responding. Multi-organ failure, uncorrected acidosis, hypothermia, these are the patients to be straight taken to the ICU without wasting any further time. Okay, this I'm skipping. What are the infection control issues? So, well, see, you have to be a little cautious about who's going to meet the patient, who all are going to go to the patient's room, whether they should be wearing surgical masks, whether they should be wearing gloves, everything that you have to manage a little protocol. Correct? What are the neonatal issues if sepsis develops in the puerperium? So how do you have to take care of the baby? Obviously, pediatrician is there to take care, but you as an obstetrician should know particular things. The baby is especially at risk to streptococcal and staphylococcal infections. Okay, I have given lectures on GBS, have I not? The group B streptococcus, which is very, very important for newborns. That infection, the mother can never have any problem, but newborns have very severe sepsis. EOG, yes, early onset GBS. Okay, fine. Obstetrics is about to start. I'm going to be including this lecture separately because this is a very important aspect of, neonatal morbidity. If either the mother or the baby is infected with invasive GAS in the postpartum, both should be treated with antibiotics. A baby, a neonate who's taken birth from a patient who's turned septic after a couple of hours or one day, immediate notification to the NICU people or to the pediatrician should be given so that they get guarded on the response of the child, because any patient who just became septic after maybe a day or so, she never had those antibodies that she has given to the neonate. So because of that this particular neonate has to be taken again very seriously. This thing has to be notified to the pediatrician that you just looked at the neonate of this particular patient. She was all right before, but today she's developed high grade fever, and I just want you to look at the baby as well. Now, indications of prophylaxis to family and staff. This is not important for you. Can the sepsis and puerperium be prevented or detected earlier? Yes, any day. I have given you enough lecture on how to detect it early, how to take it seriously. But this part I wanted to teach you specifically. Guys, this can be asked you. If I was an examiner, I would have definitely asked you the difference between staph and strep, toxic shock syndrome differences, because there are so many and so specifically given that I would have definitely asked you this question. So this table is entire for them. First of all, just see this. The essential criteria. Fever for staph, I'm just talking about staph. Just have a look at this. You will call it a probable staph infection if she has 4 of the 5 clinical findings. These are the see 1, 2, 3, 4, 5. These are the clinical aspects. Okay. So if she has 4 of the 5 clinical findings positive, then she has a probable staph infection. And if she has all the 5 clinical findings, it's a confirmed staph infection. Now, what are those 5 clinical findings? Fever more than 39.9, so almost 40 degrees. Fever, very high fever I'm talking about, right? Very high fever. If she's having a rash, a diffuse macular erythema, okay? If she's showing desquamation of skin, 10 to 14 days after onset of illness, especially palms and soles, right? She's going to have desquamation. Hypotension, that means the systolic is going below 90. All right. And one of these other multi-system involvement, 3 or more, systems affected, like, for example, vomiting or diarrhea. Okay. Severe myalgia or elevated creatinine. Vaginal, oropharyngeal or conjunctival hyperemia. Okay. Mucous membranes are involved. Creatinine. So see, I'll tell you, certain things both strep and staph both have. For example, renal impairment both are going to have. Liver impairment both are going to have. Respiratory distress both are going to have. I think even mucous membranes both of them have. Generalized rash also both of them have. Coagulopathy I see more here. I don't have to see here, but yeah, here you have muscular weakness. Severe myalgia in case of staph. You do not have that over here. And here you have mostly you have this, you have this soft tissue necrosis. Wait, I'll just mark it for you so that it's in one shot you're able to understand what specific you have for staph and what you have for strep. So these are very specific features, they are different for the, otherwise you have the similar things. Anyways, we were on staph, and let's finish off staph. So these are certain multi-system involvement. So you can have gastrointestinal system involvement, you can have vomiting and diarrhea there, you have muscular system involved, you have myalgia there, you have mucous membranes being involved, so they'll have red congested hyperemia, you can have renal system involved, you have creatinine high, you have hepatic system involved, total bilirubin high, hematological, you have platelets, deranged, central nervous system disoriented. Amongst them, if you have any signs of staph, plus each of these signs, So if you have all the signs, then definitely staph. And if you've got 4 out of 5, then probably it is staph. But in strep, you have isolation of group A streptococcus from here. Let's just understand the criteria. The probable criteria is that it meets the clinical case definition, plus the isolation from a non-sterile site. I'll talk about what is sterile site and non-sterile site. And the definite is the one that in which you have all the clinical case definitions there, plus there is an isolation from a normally sterile site. That means usually a site which is normally sterile, from there you have isolated strep. So now let's go back and understand what exactly is streptococcal shock syndrome. Toxic shock syndrome. Again, I'll just tell you the case classification. The probable and the definite. Here also you had probable and definite. Here you have probable means the clinical criteria along with the isolation from a non-sterile site, a site which might not already be sterile, right? But here is a normally sterile site. These are normally non-sterile sites. These are normally sterile sites. So if you get if you can get the strep from here, well, in this case it is probable. But if you get a strep from here, isolated and cultured, well, then this is a definitely streptococcal toxic shock syndrome. Correct? So let's start again. Isolation of streptococcus from a normally sterile site, that means blood is sterile, cerebrospinal fluid is sterile, peritoneal fluid is sterile, any tissue biopsy is sterile. But what are asterile sites or non-sterile sites? The throat, vagina, sputum, all these are some oral cavity or vaginal area, or this throat, of course. So here you have, these are associated with opening. So here there's a very good possibility of it being non-sterile. But things like blood, cerebrospinal fluid, peritoneal, they are all those cavities of the body where infection hardly reaches. They are the sterile site. So if you can isolate from there, it's definite that it is streptococcal infection. Plus, like I told you, multi-organ involvement. So you have hypotension plus. Hypotension is a must. Hypotension along with 2 or more of the following. That means if she has a renal or she has coagulopathy, or she has liver involvement, or she has respiratory distress syndrome or tissue necrosis, she is going to be a probable or a definite carrier of toxic shock syndrome, which is streptococcal in origin. Guys, please take this seriously, because this can come up as any day, the difference between the two. Now, this is just a repetition of what we had considered with what we had studied before. These are just nothing but diagnostic criteria for sepsis. And I would recommend all of you to read it slowly, silently, word to word by yourself. Once the PPT is up on your regular class folder, just go through it silently, slowly, so that you're able to understand how important this chart is. It tells you the different diagnostic criteria, correct? All these are very, very important. Okay. See, ileus, absent bowel sounds. Thrombocytopenia, coagulation abnormalities, creatinine rise, oliguria, very, very important. This is very important, arterial hypoxemia. Correct? Now, another of my favorite charts, another of my favorite slides. These are the antibiotics of choice for different things which you can have in your clinical scenario. Correct? This I would love to share with you. Before that, let me just share with you this slide, because I want to tell you how important this thing is. Correct. Let's just try to see where clindamycin is falling in the spectrum. See, MRSA, some MRSA she's able, clindamycin is able to conquer. The others, mostly the anaerobes are being covered by clindamycin beautifully. It's covering the gram-positive very beautifully. It is covering gram-A strep very beautifully, but not so much the gram-negative. Do you see? So that is the drawback of clindamycin. Gram-negative being ignored, but gram-positive and anaerobes are being covered by clinda. So here the rescue is given by meropenem, imipenem. Yeah. So it's covering not only gram-positive but also gram-negative over here. So if you combine it with clinda, your entire spectrum is covered except for MRSA. Remember that, except for MRSA, where only vancomycin is going to help. Correct? So it's a beautiful antibiotic to be, but so is our cefuroxime. See, cefotaxime we give to so many patients, right? That's our best. So it covers gram-positive and most of the gram-negative, but except for it's leaving behind pseudomonas. See, cefotaxime is leaving behind pseudomonas, which is already being covered by the tazobactam or meropenem. See, and plus it doesn't cover the MRSA, doesn't cover that. So along with it, what we usually have metronidazole. So cefotaxime along with metronidazole, and then we have gentamicin. Gentamicin covers this as well. Where is gentamicin? Yes, it's covering the pseudomonas and it's covering all the coliforms. So this is our triple antibiotic cover, which works very well. But so does clinda and the meropenem. But it does, in that case, you'll have to add vancomycin. Correct? Can you now, appreciate this chart, guys? It's a beautiful chart, and I'll just take 10 minutes more to just make you, remember this important chart. Mastitis is beautifully, managed by flucloxacillin. Okay, that's a first choice. Flucloxacillin along with clindamycin. Correct? And if it's MRSA positive, vancomycin plus clindamycin. But clindamycin is coming for breast, problems. Cesarean section wound infection or IV cannula site infection. So if you have a site infection or a stitch infection, go in for vancomycin along with clindamycin, because mostly the stuff, by the time you'll come to it, it's a MRSA. Correct? Cesarean section wound infection or IV cannula site infection, you can go in for. If it's MRSA, you go for vanco and clinda. If it's MSSA, now MSSA, I'll just tell you, this is nothing but methicillin sensitive staph. So this is methicillin resistant, this is methicillin sensitive staph. So if it's methicillin sensitive, you can go ahead for flucloxacillin, clindamycin, just what you were doing with the breast abscess or a mastitis. Endometritis, gram-negative anaerobe strep. So you can go in for genta, you can go for cefotaxime, you can go for metronidazole, or you can just go for clinda genta. This is also very good. Acute pyelonephritis, well, very good idea is to give meropenem. Very good idea. But this is basically your bacterial sepsis after pregnancy. So you have to see for those cases which you can easily go ahead and give, your antibiotics, and they should not be too much into the breastfeeding. Cefotaxime, gentamicin, they are very, very safe antibiotics for breastfeeding as well. For the breastfeeding babies, and no problem at all. Toxic shock syndrome, you have so many that we just discussed. Consider IVIG is very, very important right over here. Severe sepsis with no focus, please go ahead with meropenem plus clindamycin plus gentamicin as the first choice. Correct? And guys, with this, I finished my lecture today on the sepsis. These were very, very important charts which I wanted you to have. You keep them in your phone, and remember, if a patient comes to you post surgery with any of these problems, you can always suggest to your consultants, ma'am, why are we not giving flucloxacillin to her? Why should we not start her on vancomycin? Why are we not giving clindamycin along with meropenem to her? That's the best choice. And she'll be very happy, I hope, with you with this. So if you've got any doubts, guys, I'm here to address your doubts. If you feel that you need to study a little more regarding anything else, please feel free to approach me. I would love to introduce it in my next class, okay, which I probably would be taking if you feel that it's not covered properly. But if you think there are 1 or 2 points are missing, I can always just keep posting it in the channel. And I love it when you all ask me questions in the channel, because then that gives you an opportunity for the other students to also go through those notes which I'm posting. Sometimes I post it from my side, sometimes when I get too busy I forget, but I usually make it a point to keep giving you the learning snippets. Nazima, if your question is when to put the patient in HDU, see, it's a very difficult decision whether the patient should be in HDU or it should be in the labor room suite. Usually a patient of sepsis, the first place she goes into is the HDU only, the high dependency unit. But if she gets even more sick, she has to be on vasopressors, or she's not maintaining urine output well, or she has to be on ventilator, she's shifted to the ICU. But if you're keeping a patient only for IV antibiotics, she's improving, that you can do in the HDU also, and you can shift her into the ward also. But HDU usually for a little higher sensitive patients who are maintaining blood pressure on IV fluids, or whose urine output is borderline low, or the ones who are still complaining of fever, not completely okay, they are the ones to be the candidate for HDU admission. The others who are very, very sick and who are not responding very, very well, like I told you, who need vasopressors or who need ventilatory support, they are shifted immediately to the ICU, which I just told you before. Any other question, guys? Yes, that's very true. You have to read this repeatedly, especially these charts which I gave you towards the end. These antibiotics, very important antibiotics. I mean, nobody's going to forgive you if you do not know. At least see, I've given you the names, not the doses, because mostly all of them have the similar doses which we just discussed. You've got vancomycin, you've got clindamycin, you've got flucloxacillin, you've got where do we have meropenem, you have gentamicin. So these you have read these antibiotics so many times, you know the doses. And even if you do not know the doses, I don't expect you to know all the doses, but at least you should know that in case of endometritis, we are still going ahead and giving our age-old Taxim and Genta and metronidazole. Okay, and along with maybe, if required, Genta and Clinda and Cipro. All right, guys. So with this, I finish my lecture tonight. Thank you so much for being excellent audience, as you always are. Any doubt, guys, please feel free to approach me. Either WhatsApp me, put it on the channel. I have no problem. Let others also answer you. I'm more than happy when friends answer to each other's query. And it gives you not only a boost in confidence, but it also gives you a sense of, belonging to my class, my academic, quest. And you remember those things which you teach to others. Very important. So thank you so much, guys. Thank you so much for being there, and Happy New Year from my side to everybody. I was just forgetting it. Happy New Year, everybody. May you bring the new year with style, a lot of happiness, and a lot of studies, so that you excel in your academics. You excel. DNB exam should not look like an exam for you people. You study so much every day, it becomes easy and easy and easy. See, I always request all my students who call me at the start of their, when they usually the students nowadays, they start calling me right from the time their admission has, in the DNB seats. They've been allotted the DNB seats. Some of them are talking to me when they're going for counseling. Some of them talk to me once they've been allotted the seats. And I tell them only one thing, that, now that you've got yourself admitted, go see your environment, the work culture, spend 3 or 4 months to understanding the work environment, and then slowly and steadily start your, journey on for DNB. I was, at that time, I did not have anybody to guide me. It was very difficult for me to first procure the material, start studying, and now everything is there on at the click of a button. There's so many things already there on the net. You don't even require to hunt so much, but it's a very lost cause when you do not know what to study when. So when you join anybody's classes, you get a very good vision as to this is the way I have to go. These are the the most important number of topics that you have to do. Most of the platforms I don't know how many of them are teaching DNB dedicated classes, I don't know, but many platforms, they give you only a bunch of some 30, 34, 35 topics and say this is obstetrics and gynae for DNB, study it and you will pass, which is not true, which is definitely not true. I have more than 200 topics, 200 dedicated topics to be studied, to be made to study, especially when you're taking up the course, and they're divided into week-wise schedules, so that you're able to understand structurally exactly the way you structure the study, methodically prepare for your exams. It's very, very important to go in a structure-wise manner, in a proper methodological manner, so that you can revise, re-revise, and re-revise. Until and unless you do that, you'll not be comfortable. And the idea of my classes is to make you more and more comfortable for exams. So anyways, Happy New Year to all my lovely students. May you have a bright and lovely future. You enjoy your studies, you enjoy yourselves, work and study as well. So my classes will continue later on in January. I'll take a couple of weeks off because of my currently ongoing fellowship, and then we'll be back to our schedule what it was before. So thank you everybody for joining me tonight. Thank you once again. Good night and God bless everyone.